Oh, yes. So here, for those of you who have just arrived, we're doing a Minty poll. Maybe we'll chat it as well. Maybe someone can chat it. This session is being recorded, and so the last one was also recorded. So if you go to that website, like there should be a link. And please put your organization and your name. And as we get going here, our first presenter is Candy Stockton. And she's an MD, a local MD who is passionate about how to provide person-centered services related to drug use. And so I know that she holds a lot of hats. She wears a lot of hats, so I'll let her kind of explain those. But as we get going, I want to introduce Dr. Candy Stockton.
Hi, I'm happy to be here today. I think we were stalling until about 12:05 to start, and it looks like it's 12:04 on my clock. So I am just going to take just a minute to introduce myself. I am a family medicine doctor, but I also have board certification in addiction medicine. And I did that because over time, I came to realize that I couldn't really meet the needs of the patients I was serving without also being able to understand how substances and how addiction was affecting their overall health and lives. And I think we're just getting ready to hit 12:05 right this minute. So unless anybody has any objections, I'm going to go ahead and get started. All right, so I was asked to talk a little bit about what person-centered care for substance use disorders looks like. And I'm going to do that, but I'm going to cheat a little bit and say that there are really three fundamental understandings that we have to have if we want to have an honest conversation about what person-centered treatment looks like. So the first is that substance use disorders are a physiologic disease. They are a real disease. They are not a moral failing or a sign of weakness or a choice or selfishness on the part of the person who's experiencing them. They are a legitimate physiologic disease for which we understand many of the pathways and mechanisms that happen. And like most diseases, diabetes, which is a really good analogy of this, it's this complicated intersection of biological and genetic factors, of the environment that we develop in and that we live in currently, of societal reactions to us, and of some component of personal choice, but it doesn't negate the fact that it is a real disease. And if we refuse to look at the science and treat it like a disease, then we're going to be stuck in this kind of moralistic panic, much like we treated leprosy, right? So for 2,000 years, Western culture genuinely believed that leprosy was a punishment from God for bad behavior. And in fact, we now understand that this is actually just a bacterial infection that's relatively simple and easy to treat and control. And because we now understand that science, we can cure leprosy or at least manage it if it's discovered in its later phases, rather than locking people away and ostracizing them from society for this punishment that God gave them for their poor moral behavior. The second fundamental understanding that we need to have is that the way that we treat substance use in this country right now is not an accident. Nixon's war on drugs was deliberately designed explicitly to disenfranchise minority communities, and particularly Black communities. So the fact that substance use disorders and the criminal punishment for substance use disorders disproportionately affect minority populations is not an accident. And even though most of us may not intentionally be doing that, when we buy into the way that we currently respond to substance use and substance use disorders, we are buying into an explicitly designed system of oppression. 1 in 13 Black American adults who are voting age are unable to vote because they have a felony history that's predominantly related to drug use. 1 in 9 Black children in this country has a parent who is currently or has previously been incarcerated, again, predominantly because of drug use. This was not an accident. This is intentional. And we need to understand how heavy the price has been for Black populations, for Latinx populations, and for Native American populations because of our explicit and implicit practices and beliefs around substance use disorder. And then the third is that while we have this hysteria around how dangerous drugs are, substances are neither inherently good nor bad. They just are. And the heroin substance that allows, that causes people to overdose and die in the street is the same substance that allows us to perform an emergency appendectomy on your child and save their life. So much of the harm that comes from substance use is not a direct and necessary consequence of using the substance. It's a consequence of our reactions to and our policies around this. For instance, the risk of hepatitis and HIV that's inherent in IV drug use is not because heroin carries HIV. It's not because morphine has hepatitis in it. It's because we systematically make it difficult for people to have access to a consistent, clean, safe supply of syringes to inject with. The risk of overdose, yes, in part is related to the fact that you're injecting a drug or taking a drug, but is actually more strongly related to the fact that we've stigmatized this behavior. And so people use alone in situations where there isn't somebody available to respond. And because we've made drug distribution a criminal activity, they're prone to less than scrupulous distributors who may be pushing out dirty or tainted supplies of drugs, or drugs that are not actually what the person thinks they're getting. So again, a lot of the harm from substance use comes not from the use of the substance itself, but from the restrictions and the situations that we have enforced on people because of our beliefs about their substance use. If we truly accept these facts, and they are facts, they're not my feelings, they're not things I made up, they're evidence-based. We have good, solid, repetitive scientific documentation of these things, and we have first-person historical accounts from people who are designing our current war on drug policies, right? So if we accept these facts, then this means that we need to change everything about the way we respond to substance use and substance use disorders in this country. And that's where person-centered care comes in. It means that much like with diabetes, we need to offer people who are experiencing substance use disorders a full range of treatment options. Everything that starts with supportive and non-judgmental treatment for their other medical conditions, harm reduction measures to keep them safer while they're using substances, to pharmacotherapy, to medicines where they're appropriate to help stabilize the changes because of they're experiencing because of addiction, to residential and inpatient treatment options. They need this full range of options. And we need to recognize that, again, much like diabetes or any other disease, the patient, the individual's goals for treatment and for outcomes need to be our primary goals. So if I have somebody who has diabetes and I say to you, I want your hemoglobin A1C to be under 7 because I know that's the level at which it lowers your risk of having amputations and kidney failure and dialysis and blindness from your diabetes. But you say to me, yeah, but the most important thing to me right now is that my blood sugar sometimes drops dangerously low and I pass out and I'm afraid I'm going to die while I'm driving, or I'm afraid that I'm going to set the house on fire because it'll happen when I'm cooking. That needs to be the focus of my treatment. I don't get to decide as a doctor or as a caregiver what your priorities and your goals are for any other disease. It's my job to support you in making those changes. And this is the one disease where we feel like we have the right to tell people what their goal of treatment needs to be and enforce that on them. As long as we allow our moral judgments and our kind of hysterical panic around this to guide our treatment, we're never going to offer person-centered care. The other issue has to do with the legal implications of having a substance use disorder. There is no other medical disease for which I, number one, get to label you a criminal and take away your rights. I mean, we let people who are diagnosed with dementia maintain their voting rights in this country. And you can make a legitimate argument that they are not capable of making a rational decision about voting, but nobody goes through and revokes their voting rights, right? But somehow, because you've had a substance use disorder and you've been convicted of a crime because of this, and the crime is just that you have a substance use disorder, right? We think we have the right to take away your right to vote, to restrict your access to other things, to restrict your access to getting loans to go to school so that you can have a better future, right? We take away all your rights, and there's no other disease that we do this for, and the most egregious and the most dangerous way that we violate people's rights when they have a substance use disorder is by destroying their families and taking away their children. I would venture to guess that every single one of you have sent children home to families who are smoking at home without a second thought about it. We know that cigarette smoking among parents is dangerous in many ways for children, and we know it leads to long-term health outcomes for those children. And we never think twice about sending kids home with those families because we think it's good for them to remain with their families. In fact, smoking in your home on a regular basis has a larger health consequence and a larger health burden to your children than using heroin in your home does. Using heroin in your home is not particularly dangerous to your children, regardless of the horror stories that we dredge up to make a point when we want to, right? And in fact, when we take children out of their family of origin, we not only destroy that family, but we often destroy that child's future as well, because we know that that loss of their family of origin and oftentimes the break with their community actually leads to the trauma that then predisposes them to being at higher risk of having substance use later in life. So when we talk about person-centered care, what we really need to talk about is not a specific treatment or a specific way that we do this, but an understanding that this is a real disease, not a weakness, and not a moral failing. And it's no more dangerous to allow people with this disease to live in society, have the full range of rights to which they're entitled, and to maintain their families than it is for any other person to do so. When I was pregnant with my second child, I had a very severe form of gestational diabetes. And for those of you who are familiar with diabetes, you'll recognize how bad this is. I was taking between 500 and 700 units of insulin a day, which is, I like to affectionately call enough to kill an elephant. And there were many times during that process where I actually either lost consciousness or my blood sugars dropped so low where I was confused and I wasn't able to make rational decisions. At no point during that process did somebody say, you're injecting a drug that impairs your capacity to think sometimes, and we're going to take your 3-year-old away from you because it isn't safe for her to be there. At no point during that process did anybody ever have that thought. All I was ever offered was, I'm sorry, this has got to be difficult for you. What can we do to help you and your daughter be more safe in this situation? So that's my challenge to you all today. I don't need to tell you how to offer person-centered treatment or what that looks like. You just need to take a really hard look at your systems and your services and ask yourself, is this the way that I would treat a different disease? Or am I doing something different because I've bought into the stigmas and stereotypes and biases that are explicitly built into our system? And I'm going to stop there because I think my time is up, and anything else I say at this point will just be repetitive. So thank you so much for giving me a chance to preach to you today.
Thank you. Thank you, Candy. We really appreciate how you set the stage for our next presenters who are intimately involved in actualizing what you have just presented. And so let me introduce Jessica and Lasara from Harm Reduction Coalition of Humboldt County. If you guys would like to, if you all would like to say hi, and it's you're up.
Thank
Hi,
you.
everybody. I guess I will start off. Lasara, do you want to say anything before I get going, or?
I just want to say, Candy, that was amazing and powerful. Thank you so much for that high-powered, high-velocity presentation. So amazing.
Yes, always like big shoes to follow afterwards. So thanks. But also like so appreciate Candy's perspective and knowledge. And yeah, just like powerful and clear way of saying these things. Full disclosure, I had a second cup of tea, so I'm like, woo, over caffeinated. So I'll try to stay coherent and make some sense. And also really happy to see a lot of friends here, a lot of service providers that I know and that Hatcher engages with regularly. So really great to see you all. So my name is Jessica Smith. I am sort of speaking today with my Humboldt Harm Reduction Coalition hat on. I wear lots of harm reduction hats in my life for my free time and volunteer work and my actual work. So I want to talk to you all a little bit about the Humboldt Harm Reduction Coalition today, a brief overview about harm reduction and why it's so important and how it can be used, especially in the time of COVID. And then Lasara will go on to talk more specifically about services that Hatcher provides. So the Humboldt Harm Reduction Coalition is a community-led grassroots organization, and we work to promote the health and dignity of individuals and communities impacted by substance use in Humboldt County. And I know there are some other members here today, so hello. We strive to advance harm reduction policies, practices, and programs that address and reduce drug-related harms, including overdose, HIV, Hep C, addiction, syringe litter, and incarceration. This coalition includes a variety of people from all sorts of different organizations and service providers. So we've got folks from Open Door, people from Hatcher, people from Affordable Homeless Housing Alternatives, DHHS, Humboldt IPA, the Yurok Tribe Wellness Coalition, St. Joseph Health, and Crossroads Recovery. And lately, we've really been focusing on education about what harm reduction is and how it can support positive change beyond substance use, right? So harm reduction and the history of harm reduction is really rooted in people with lived experience fighting for their rights and their health and their dignity, specifically people who are impacted by the HIV/AIDS epidemic. And now, while always acknowledging and respecting that history, we have found that harm reduction can be used for a broader tool to address things around mental health, around housing. I play roller derby. Every time I put on my helmet and my pads, I'm utilizing harm reduction. I'm doing something that is inherently dangerous and still choosing to do it, but I know how I can make myself a little bit safer. Wearing a seatbelt, putting on sunscreen. If you have something like diabetes or other health concerns, and nutrition is part of that, portion control can be harm reduction. So really just sort of broadening the understanding and education around how harm reduction really shows up in our everyday lives. We've done an awesome media campaign recently about harm reduction is. And so again, like photos of our participants in the coalition holding a little sign that says harm reduction is, and then their definition of what that looks like, right? And that includes some of the things that I mentioned, wearing a helmet, using a car seat, along with, safer injection supplies, education around substance use. That is all harm reduction. And so as far as harm reduction, Candy, I think, gave a sort of great overview already, but at its core, it really is about person-centered, compassionate, stigma-free care, respecting the autonomy of people who use drugs, right? Again, like we don't disempower other people who might be having a health issue or a disease, right? But really acknowledging that a person is an individual who can make autonomous decisions for their life and for their care, and providing dignity and health the same way that we would to any other person. I work for the National Harm Reduction Coalition, and we always call harm reduction, like we refer to it as the buffet of options, right? So we like to, it's a really an umbrella for care. So, if you need at whatever point you are at in your journey, you need safer use supplies, you need education around risks, you need treatment, you want to go, full abstinence, like all of those options are available to people and really should be decided by that person, right? As provider here to help support people into making any positive change. And so again, I mentioned abstinence, and that is a tool and an option for people, and it is something that harm reduction can support people in. I think oftentimes we think about harm reduction and abstinence as like these dueling, fighting, disagreeable things, and that is like further from the truth. For some people, their harm reduction is abstinence. They know if they take one drink, if they do one line, if they inject one time, like that's going to be real trouble for them. They're not going to be able to sort of reel that in. But for other folks, acknowledging like abstinence might not be accessible to them for whatever reason. And so providing other options, right? Whether that's medication for opioid use disorder, or just talking about the risks of sharing injection equipment, offering smoking or snorting supplies so that people who may not want to inject anymore but aren't ready to completely quit have that safer option. And so all of this is extremely important during COVID-19 because it has really created like isolation and mental health concerns for like everybody, right? And then imagine if you are somebody who has a substance use disorder, maybe you have been in recovery or, you know, have already adjusted your use to something that's more safe. And then all of a sudden you're alone, maybe you're unhoused and you were put in one of those Project Room Key hotels and now you're by yourself and you don't feel like you're not safe, right? If you're using alone, you're not as safe. And again, like mental health, the isolation, being separated from folks, that can create more use. Or if someone wasn't using, they might need to use again just because of the stress. So really being able to talk openly with people in a non-judgmental way and offering options and seeing what they feel like would work best for them in whatever situation they're currently finding themselves. We've also seen overdose rates climbing across the country. And so, you know, basic things of harm reduction, naloxone distribution and education, right? Making sure folks have access to naloxone. If you know that your clients have substance use disorder, asking them if they know about naloxone, asking them if they have access to it, even if they are in recovery, even if they're in an abstinence-based recovery program, because part of recovery is relapse. Candy can probably give you the exact number on how many times that happens, you know, before somebody gets all the way to abstinence or long-term recovery, right? So really just being transparent about like, hey, you're not messing up if you decide to use again, but we do want to make sure that you stay alive. So you continue to have options to make any sort of positive change that you want to. Other things that COVID has impacted are inpatient recovery services, right? So the need to quarantine before accessing those services has created a barrier for some folks to seeking that kind of treatment. In other ways, COVID has actually improved and taken away some of the barriers to medication for opioid use disorder. So we're seeing this big boom in telehealth, and Lasara will talk more about this as offered by Hatcher. But telehealth services for medication-assisted treatment is like amazing and provides opportunities for folks who have otherwise been unable to access treatment resources. Similarly, the rules regulating methadone have been loosened a bit, which we really hope stay even after the pandemic. So folks are able to do take homes more easily and not have to show up to a clinic every single day, which can in itself be a huge barrier. Let me see, did I get all those points? Sorry, trying to move through this so I can give Lasara enough time. So yeah, those are just sort of like the broader things of like what's going on with substance use, with treatment, with harm reduction during COVID-19. And like I said, Lasara is going to touch specifically on Hatcher, but I just want to give like a really brief overview of some other harm reduction services and champions in our community. Oh, it looks like my time's up. Okay, really quick, like super fast. Public Health in NORCAP, they do syringe exchange harm reduction services. Aegis, that's our methadone clinic. They have a harm reduction lien. They're not going to kick you out of services right away if you miss them. Raven Project, they do great like preventative stuff with transitional age youth. ED Bridge, I saw Yvette Cerna in here. People can get inducted into Suboxone through the emergency department at St. Joe's. Brian Olson at Eureka Community Resource Center at St. Vincent, Humboldt IPA, that's Candy, Patty Torres, Vanessa Verdiak, DHHS, they have harm reduction groups for folks that are still actively using. Get a hold of Rana West for that. AHA does great stuff with housing. They have their no barrier shower trailer, which also provides referrals and lots of other services. Waterfront isn't abstinence-based only, but Wes is like a major champion of harm reduction. And yeah, definitely refer folks to his services. And then Open Door and their Suboxone program. Thank you all.
Awesome. Thanks, Jessica. All right. I'm Lasara Firefox Allen. I'm the Executive Director at Humboldt Area Center for Harm Reduction, also known as Hatcher. We are offering a lot of different services that it has been an interesting challenge to accommodate our populations and communities within the frame of COVID-19. So we have increased our services to include PPE for primarily unhoused populations, which is a huge, I think it's been highly effective. The harm reductionists in the community have been instrumental in making sure that COVID-19 doesn't hit the unhoused population as strongly as it could have otherwise. We've been on the ground getting masks and hand sanitizer and gloves out to those that need them. We offer overdose prevention, education, and supplies. We offer safer use equipment and supplies. We offer substance use navigation. We have substance use navigators on site, and we also do outreach services. And that is, as Jessica had mentioned, through our partner Bright Heart Health, who offers a low barrier telehealth option for folks who are interested in access to safe supply and interested in continuing in their harm reduction approach oriented recovery model. They don't require testing. They don't require abstinence. And so it is a perfect fit for our population. We have over 75 people enrolled in Bright Heart Health, and our retention rate is over 93% currently. And this is in no small part in credit to our substance use navigator, Christina, who is out there on the ground interfacing with our people every day of the week and going to their homes when they aren't capable of getting to the site. So we do a lot of on the ground outreach in that regard. We also do HIV and HCV testing. We have a drop-in clinic from noon to 2 on Thursdays, and then by appointment on Wednesdays as well. Jessica is one of our testers, and so if you want to see Jessica, you can come in on a Thursday afternoon between 12 and 2. I also do some of that testing, so just come on by, drop in or appointment. We are serving our population at the door so that we don't have our folks coming in the building anymore, which has been challenging. Our location, yes, thank you. Our location is 1522 3rd Street in Eureka. We also have socks, underwear, hand warmers, gloves, beanies, sleeping bags, tents. When we have them, we have all of that right now. We have food, grab and go food options for our people and our community. So if folks are in need of a hot cup of soup, they can come on by. No need to, as Jessica said, it's a buffet of options. You can come on by and get what you need and be taken care of. And I think one of the primary services that we also offer is that we are a place where people can check in, they can charge their phones, they can use our phone if they don't have a phone in order to make an appointment or to do a follow-up. Yeah, okay, time is almost up. Okay, so I'm gonna hop to the meat of what I wanna say, which is substance use isn't always problematic or chaotic. Substance use can be a managed pattern. And one of the things that Hatcher is really invested in is in our long-term vision is the decriminalization of drug possession and use, and also the decriminalization of prostitution. Now, it might seem odd to bring that up in this context, but I think it's very important to mention that both of these are harm reduction. They're harm reduction for folks who are possessing drugs and using drugs, and they're harm reduction for people who are doing sex work consensually. The other component is it's harm reduction for the families, as Candy had mentioned. When we take families apart, the long-term ramifications for the children involved can be quite stark. As far as ACEs and continued health and mental health challenges. So yeah, our long-term perspective is toward decriminalization of drug use and possession, decriminalization of prostitution. And that will help us to maintain families in a more holistic and comprehensive manner. And to, as Jessica and Kenny mentioned, retain the autonomy factor in our interactions with people who use drugs and people who are doing sex work. All right, I think that was it. Yeah, my final parting word is just remember we're all people. And remember that most of us use substances of some sort. So thank you very much.
Thank you, Hatcher. it's good to know. I mean, there's a lot of that stuff that I didn't know, and it's very helpful. And so, like I mentioned in the chat, like we will be providing everyone's contact information at the end if you have more questions. But our next presenter is Wendy from Partnership, and what is the latest updates for Drug Medi-Cal?
Great, thank you. I'm going to share a really quick PowerPoint. You know, we're running short on time here. Let's see if I can make this work. Okay. Oh, look at that. Technology decided it wanted to work today. Well, thank you very much for having me. I am the program manager for the Wellness and Recovery Benefit, or more commonly known as the Drug Medi-Cal Organized Delivery System for Partnership Health Plan. And we cover, for the Wellness Recovery Benefit specifically, we cover 7 regional model counties. Those include Humboldt, Lassen, Mendocino, Modoc, Shasta, Siskiyou, and Solano. You can see them there on the map. If you're familiar with Partnership Health Plan, you know that we also cover other counties as a managed care plan. And you can see there on the map that Del Norte, Trinity, Lake, Sonoma, Napa, Yolo, and Marin are not included in our regional model, but do offer FUD services in just a different way. Del Norte, Trinity, and Sonoma are still under state plan for FUD, so they offer a different range of services. And Yolo, Napa, and Marin, excuse me, Yolo, Napa, and Marin do fall under the organized delivery system. So their services are similar to what we offer in those blue counties you can see there on the map. A couple of really key things to the new system of care is that it allows a full continuum of services for SUD, and we have a central access line. It also standardizes the medical necessity through the ASAM screening and assessment tool. And then it also opens up, because we are a managed care plan, it opens up care coordination. So pretty much one of our really big goals is to care coordinate across the system. So primary care, mental health, and substance use, and kind of looking at it in a really holistic manner. As I said, it opens up available levels of care. So access to outpatient, intensive outpatient, withdrawal management, or detox, as a lot of people are aware of. It opens up MAT, as well as the MTP, the opiate treatment programs. Residential treatment is now covered under Medi-Cal. Recovery services are covered under Medi-Cal, and case management is actually a service that can be billed to Medi-Cal for those Drug Medi-Cal certified agencies. It does cover services for non-Medi-Cal members as well, depending upon which county the beneficiary client is coming from. So if you would like to hear more information about that, because we're running short on time, I'll just throw that out there, that there is some coverage, but you can contact me independently if you'd like to chat a little bit more about that, and I'll focus just primarily on those Medi-Cal in those 7 counties. We do have a central access line, as I mentioned. You can see that on the screen. We contract with Beacon Health Options, who some of you probably know as the mental health access line. And so it is the same phone number. You just go down kind of a different tree to find the substance use services, as well as that connection to treatment. So they do a short screening, and then basically they will connect the client directly with a warm handoff to the care provider. The screening can also be done through county staff. So I saw Raina was on the call, and they have a few staff at Humboldt County that can do a direct referral, is what we call them. So they screen, and then they connect them to the appropriate level of care as well. Residential is the only level of care that requires a prior authorization. We have a treatment authorization process for that. And one of the great things is that it opens up the ability for transportation under partnership. So people can be transported to their substance use outpatient programs. They can be transported to a residential facility. If it is in even another county, we've had people transported from Humboldt County down to Solano. We've had the opposite happen as well, just in the 7 months that we have been live on this benefit. A couple of things that might be important to some folks here on the call is we do have a really lovely trifold brochure. We have an electronic version that is on our website, but we do have printed availability as well. So if you would like to have some of these at your facility, please feel free to email me and we will figure out how to get them to you, whether it's through Humboldt County or I mail them directly to you. So you can see here that that is the front of it. This is what the inside of it looks like, provides all that basic information of treatment services, has the central call phone number there as well. A couple of other resources just to be aware of. We have a Partnership Wellness and Recovery page. The link is right there, and I'd be happy to share this PowerPoint with you if you would like. Also, we have webinars on our website around SUD treatment and for providers and case managers, all kinds of different resources there and educational opportunities on the website. So you might want to take a look there. And then I will mention for Humboldt County that we have 4 specific providers in Humboldt County, Crossroads, Humboldt Recovery, and Waterfront in the residential realm, and then Humboldt County as the outpatient provider. But one of the really great things about the way we have set up this benefit, like I said, it covers 7 counties. A Humboldt County beneficiary could access treatment in any of those other 6 counties. And so if they were looking to maybe get out of, you know, the area that they are in, feeling like that would help in their recovery, and so they wanted to go to a residential facility in, say, Shasta County, that is a possibility, and it would be covered under their Medi-Cal if it was a medically necessary treatment. The other thing about it, sometimes our treatment providers get full. And so it opens up that access to any of the other providers in the 6 counties. So you can see right there that there is a link to our provider directory, but know that there are many options outside of just Humboldt County for Humboldt beneficiaries to access treatment. I think that was my last slide. So I will stop sharing there and just know that I can answer questions if you have any, or you can email me and contact me directly. So thank you very much again.
And thank you, Wendy. And I have on my notes here that perhaps Candy was going to do a 1-minute overview of services available for private insurance. Is that the case still?
Oh yeah, so I was gonna loop back. So partnership and the benefits they cover are really extensive and really amazing and are a very needed service. But actually in this community, it's very difficult for patients who have private insurance, so commercial insurances, to access treatment. And while it is possible for them to get into Open Doors Clinic and they will take them, it can be difficult for them if they're not established patients there. So there are a number of doctors in the community who actually will provide addiction treatment, both opioid use disorder and alcohol use disorder, as well as other addiction treatment, including the services that we offer here at the Priority Care Center, the Humboldt IPA. So do know that there are some resources that are available for patients who do have commercial insurance, although it can be a little bit harder to figure out where those are and how to access them are. We're blessed to have such easy access for patients who have Medi-Cal and through partnership, and with uninsured patients through a variety of programs that can get them access to treatment at both AGIS and Open Door if they have no insurance. But private insurance remains a difficult problem in this community.
Thank you. Now, one of our goals and one of the things that the people who attend the roundtable really appreciate is the networking ability to ask questions, and it's a little bit harder with the pandemic, but we still want to try to do that as much as possible. And so we want to provide the next few minutes the opportunity for people to ask questions, have comments. And so if you'd like to chat those, our co-host will try to review those and prompt you if you so choose. And so, and then after that, what we will do is do a little bit of a wrap up of a survey on what people are interested in next time, and kind of a plus delta survey as well. And so as those questions are coming in, I believe Tricia will unmute you and give you a chance to ask a question or ask for some clarity.
Great, and we've got a couple questions thus far that have been kind of trickling in. So Candy, right when you were speaking about the available treatment options, we did have a question of how do you find those doctors who are available for treatment?
I wish I could tell you that that was an easy thing to find. So you can actually use SAMHSA's website to look for waivered providers, that is doctors who can prescribe buprenorphine in the community. I can tell you for any patient that has a commercial insurance plan, so that's all of the kind of the standard ones that we handle, Blue Cross Blue Shield, as well as United Healthcare and others, which I'm probably not thinking of right this minute. They can be referred to the Priority Care Center. We will accept them here. And a number of doctors in the community, if I could say this, low key provide treatment for alcohol use disorders as well. But unfortunately, there is not, to the best of my knowledge, a central list that you can go to and look at that. But I would encourage you to talk to the doctors that you do know and find out, because more of us do offer that treatment than people realize. It's just there isn't really a central repository for that information. And maybe that's something that we should look into developing.
Should people
Candy,
ask for insurer?
I'm sorry, I missed, I think there was two people talking and I didn't catch what either one of them actually said.
Should people contact their insurer to find out local providers that offer that?
Sadly, that's generally not up-to-date information when they do contact insurers. So they'll either give them the names of people who are, not currently practicing in the area or not anywhere near as close as I think they are. What I would suggest is that if you have private insurance, hopefully you have a primary care provider that you can talk to who should be able to help you connect with those resources. And if you don't, reach out to the Humboldt IPA and we'll try to help actually make those connections for you. We do actually run a resource website that has a lot of information that's available, and I feel so embarrassed right now that I cannot give you the link to that, but we have a phone app that lets you link to resources. I think I saw that Patty or Jessica, some of the people from our organization might be on, so I'm going to ask if they are and they have that, if they can either drop that in the app or pipe up and let one of you guys know so you can push that information out.
and then Candy, can you just clarify the Humboldt IPA for folks?
Sorry, the Humboldt Del Norte Independent Practice Association, and you can just Google Humboldt IPA online and it'll take you to our website where you can find a link to that. And I see that Carrie helped me out here, and the link is the resource hub at .inchin.org, and it'll take you where you can search primarily right now to resources that are available for people experiencing substance use disorders, but there are also resources for housing and mental health and other types of needs that you can search, and you can search it by insurance type, which is helpful.
And then just to add on to that, there was a chat in from Michelle Hernandez that Redwoods Rural Health Center does also have a medication-assisted treatment substance use disorder program as well. And then Taffy, I'm wondering if you can help me to unmute C. Hunt. There, she had a question.
Absolutely. Give me just a second. And actually, C. Hunt, if you can unmute yourself, you're welcome to while I find you in the group of people. Give me 1 second.
While Taffy is doing that,
It looks like she's unmuted.
okay.
And I can see you talking, but we can't hear you, unfortunately. No, it looks like your sound is acting up. I'm so sorry. Do you mind chatting us your question?
And while she's chatting that in, there's another question. Does anyone know what opioid RX rates are for Humboldt County in comparison to other counties and states?
I wanna say we recently got some data like that from RX Safe Humboldt. I don't know, Candy.
Yeah, so there is the California opioid surveillance dashboard, and you can go on and actually look at rates of prescribing and overdose and other factors related to substance use by state and by county and break it down. But I can tell you, well, I can't give you the exact numbers off the top of my head, that historically the rates of opioid prescribing have been higher in poor rural white communities. And so the prescription pain medications that we prescribe, that's always been more of an issue in communities like this than in more urban communities. Our rates are higher.
I think we have seen a decrease, right, over the last year, and a decrease in overdose deaths related to prescription opiates.
Yes, we've definitely seen a decrease in prescribing over the past 3 to 5 years as those rates have gone down. It's complicated what that actually means, though. Does that mean that people are appropriately being lowered off of medications they shouldn't have been on in the first place? Or does that mean that we're reflexively and legislatively being forced to take people off of medications that maybe are not necessarily in their best interest to do so? So it's a little hard to actually just kind of use the across the board prescribing rate and changes in that to determine whether we're providing better medical care or not, because it's a very arbitrary number.
So it looks like the question ended up being, are there substance use treatment options for youth? So are there any programs up here for youth?
So I will take 16 to 18-year-olds. And I believe the county has some services. I'm going to shut up because I don't know the details on that, but I believe the county has some services that are targeted at youth as well. I'm hoping there's somebody here who can speak to that.
I can speak to it. My name is Raina West. I'm the Substance Use Disorder Administrator for County, and we have an outpatient. It's both intensive or non-intensive services for anyone 12 to 18. And you can call by calling our main number, and they'll connect you, or email atp@co.humboldt.ca.us, and I can put that in the chat. Thanks.
Lasara, do you know, so historically Hatcher has not provided syringes to people under 18, but do you know if Bright Heart is available for people 18 or older?
I don't know the answer to that question, and I can reach out to our contact there today and find out. And if folks want to reach out to me at hatcher707@gmail.com and follow up with that, they're welcome to.
So in general, Bright Heart is generally available for 14 and up, but I'm not sure if your guys' agreement, is okay with that. But in general, Bright Heart usually will serve 14 and up.
Great to hear. Thank you.
And just to recognize and call out that when you're talking to youth, the drug most commonly used by youth in our community is actually alcohol, and it doesn't require special licensing or treatment to do that. So that is something that can be addressed by other doctors as well. And we don't want to forget that while we're focusing on opioids, that alcohol is taking a tremendous cost on our community and on our children.
So one question I'm wondering if the panel can respond to is, how can we collaborate to change systems and policies that have been enacted to marginalize and disfranchise people who use drugs? And what are some of the efforts people are aware of that are going on in terms of that systems and policy work? And I know Lasara, you touched on this a little bit.
I'm actually going to jump in and cut in front of Lasara on this, because I think when Lasara talks about needle exchange programs, people think she has a vested interest, and they don't take those seriously. So full disclosure, I am not associated with Hatcher anyway, although I'm a big fan of the work they do. And I'm a fan of that, not because they're amazing people, although they are, but because the work that they're doing is evidence-based. We know it works. And so I will call out actually a decision that was made recently in our community, although I may know it may not be popular to do that. Our syringe exchange programs by city mandate are limited to a one-to-one exchange of, you have to bring in a needle to get a needle back. And in fact, the science and evidence behind that that's been researched over decades at this point clearly tells us that actually increases harm to the individual getting this services, and increases, and I know this seems counterintuitive, but it actually increases the amount of syringe litter and peripheral harm when we put those in place too. And yet somehow we have this bias because we believe somehow that if we pass out more syringes, there's going to be more syringes on the street. And that, and so our biases about what we think and believe about substance use make us enact policies that are the opposite of what science tells us, which is that unrestricted needle syringe or needle syringe exchange programs or syringe supply programs actually lead to the best outcomes in terms of reduction of disease transmission, engagement around additional support services for people who have substance use disorders, and reduction in syringe litter and harmful litter in the community. So I think that's a great thing to do. And I just want to call that out because I want you to know that when Lasara says it, it's not just because she's protecting her own business interests. It's because this is what the science tells us, and we should know better.
I can't really top that. But yeah, syringe services are there to take care of not only people who use drugs, but the communities that support them, and all of us, in other words. So the harm that radiates out from restriction of access to safer use equipment is harm that affects the whole community. And so it's important to even if you are having a hard time finding compassion for people who use injection drugs, and I think some people do have a hard time finding that compassion, I encourage you to cultivate that compassion as much as possible. Even if you can't get there, realize that by restricting services to those folks that do use injection drugs, you are imperiling the community as a whole. The ramifications filter outward. A lot of people also don't think about the fact, like we talk about bloodborne pathogens and transmission, and the ones that come to mind are HIV and hepatitis C, but also syphilis had 170 something % spike in Humboldt County the year before last. And so syphilis is also transmissible as a bloodborne pathogen and by injection drug use, and in other ways as well. So as syphilis spreads throughout the community, there are different ways that it can be spread. And as when we marginalize folks that need access to services, we're, as I said, imperiling the whole community.
Yes, like we are coming to the end of our time. And I want to make sure that we have enough time for this final wrap up and feedback loop, because we are sincerely interested in knowing what is useful and has and what our community of service providers want to see in this time. And so with that, I think Trisha's going to launch a poll of, and this should be real quick. So if you could just answer it. And as people are answering, let me just go ahead and thank all of our sponsors. It's Humboldt County Child Welfare Services is one. Humboldt County Network of Family Resource Centers, and that's Taffy, you've heard. And St. Joseph's, not the St. Joseph's, but
I'm gonna pop
Tricia.
in, Nate. It's
Tricia.
North Coast Clinics Network.
North Coast, yes, indeed. And so we are part of the group that is interested in having people together to figure out how we can provide services to our community in the most effective means. And so please provide us feedback. And let me see, are we going to end the poll? Oh, 82, because we have one more.
Yep, I will end this one. And let me just launch the second one. Second one is up now.
So if given the choice, if you have strong opinions, any thoughts on topics for the future, because we are committed to do at least 2 more. And if there's positive feedback and people find it useful and beneficial, like we will reassess it at then. And so just to announce, the next one is going to be the first Wednesday of March, same time. Look for the email. I think I'm supposed to say something else probably. The planning, yes, the planning committee, and like there will be a link to the video, and on there, I don't know if we, oh, there it is. And here's the contact information for all of our presenters. And I know that all of them are passionate like about this issue. We hear from everyone that how we handle drug use in the community really affects our goals of wellness. And so it's a complicated topic. It's ripe with pitfalls. And so we want to make sure that we do it thoughtfully, and perhaps we will continue. I just want to thank everyone for showing up. This is an amazing turnout, like despite the conditions. And so thank you so much for our presenters. Thank you so much for everyone that showed up. And we will see you soon, hopefully next month. I'll look for the video that's going to come out and pass it on to your friends and coworkers.